So I'm here with Dr. Marcella, or is Marcella Walker? Is it
Marcella, thank you.
Marcella Walker, who got in touch with me from Colombia about osteoporosis and SSRIs. And so what I would like to find out, first of all, is what is the study you're doing and what are you looking for?
Thank you. So we're looking at the effect of depression and SSRIs on bone health in women after menopause. And as you know, osteoporosis is very common amongst women after menopause, and depression and SSRI use are also common in this population. So there's some epidemiologic data that suggests there's a link between use of antidepressants, certain types, and fracture. But the mechanisms are not entirely clear. So we're looking at potential mechanisms of bone loss and fracture in this group of women with depression taking SSRIs. And so the study is an 18-month longitudinal study. Women come about 5 times over that time frame, and we look at non-invasive measures of bone health. So we're looking at bone density as measured by DEXA, which is the gold standard test for assessing bone health. We also use some tools that are being used just in the setting of research. So we have what's called a high resolution peripheral quantitative CT. So it's a fancy CAT scan that can non-invasively look at the microstructure of the bone. So we can look at bone quality in addition to quantity. And there's some really interesting techniques that can be applied to those images to look at bone strength. So we do that multiple times over the course of the study. We also look for vertebral fractures using a technique called vertebral fracture assessment, or VFA. We do body composition. So we look at changes in fat mass and muscle over the 18 months. And then we assess things like muscle strength and various physical function tests.
So, my first question is, how did you get interested in this particular area? And were you noticing a correlation between women in your practice who were taking SSRIs and women who had osteoporosis?
Well, not necessarily. That's a great question. It wasn't really something that I picked up on, but there is this large literature linking the two. And here at Columbia, we have a group of scientists that do basic research, Gerard Parcenti and Patricia Ducey, and they found that in mice, serotonin regulates bone health, and that SSRIs actually cause bone loss. And so it was coming from that mouse data that we got interested to see, hey, is this applicable in women? And is this, what is linking potentially SSRIs to fracture risk?
And when was that mouse study finished? Like, how long ago did we know that mice who were taking SSRIs were losing bone?
Probably for a decade.
This is, by the way, I consider myself somebody who reads about women's health all the time. I'm not a doctor, but I am on JAMA. I am reading Eureka alerts. I'm reading all the literature, and I never heard of this. And this, like, once again, like, why aren't we? That's an important piece of information, maybe, for women to know before they start taking SSRIs.
Yeah, and I don't want to sort of overstate the results, because what is true in mice is not necessarily true in humans. And so, there are some suggestive data in humans that fracture risk is increased, but whether this is due to potentially increased risk of falls or is it due to actual effects on bone is not entirely clear. And that's in part why we're doing the study. We're also trying to see if some of the mechanisms that are at play in mice are, at play in humans too, by looking at various blood tests. So, I think there's still a lot to sort out. And I think it's important to state that for women who are taking antidepressants and SSRIs, I mean, these are very important medications and they're very helpful. And we don't recommend stopping them because of concerns about bone health. I think that would be premature. Really, I think the recommendation would be more if you're concerned, ask your health provider to send you for a DEXA scan or talk to your health provider about your bone health, but don't stop your antidepressant on your own.
Right, but at the same time, what I'm thinking about right now is that for so many decades now, 2 decades now, yeah, over 2 decades since, the Women's Health Initiative data was, incorrectly read and interpreted, women who go to their healthcare providers and say, I'm in menopause, I'm depressed, they're given SSRIs instead of estrogen. And so it actually makes me really upset thinking about the idea of all these women who went to their healthcare providers, were not given a basic drug like estrogen that could have been extremely helpful for bone health, and instead were given SSRIs and now potentially could have made their bones worse. Anyway, beyond my being upset about it, what I need to know in terms of asking people who read the Substack to get subjects for you, is there sort of a limit on the number of years on SSRIs, or do you want somebody that's been on SSRIs for a certain period of time? Like, for example, I went on Lexapro for a year. Would somebody like me who went on Lexapro in 2008 to 2009 be useful, or is it much more somebody who's been on them and is still on them right now?
So we are looking for women that are currently taking SSRIs or even SNRIs. And it could be for any length of time. They could have just started them, or they could have been on them for many, many years. The group that we're comparing to, though, we're looking for women who have depression that are receiving therapy. So we're looking at both of those groups. So women who do have depression but are using non-medication or non-prescription medication, techniques to deal with it may be eligible as well.
Got it. Okay. So you're looking for two specific groups of women. Women who are being treated by shrinks right now for depression, but are not taking SSRIs, and women who are, being treated by somebody, because that person has to prescribe the SSRIs, who are taking SSRIs, but they have to be currently taking the SSRIs to be included in your study if you're in that group.
Correct. And the treatment, with therapy doesn't necessarily have to be a psychiatrist. It could be a psychologist. It could be any sort of healthcare provider, a therapist that might be providing that care. Yeah.
Okay, that's extremely useful to hear. Now, what you're in the middle of doing this research right now, right? So you can't tell me what your data says. But do you have a hunch as to what your data will show? I know that's not scientific. That's not the way scientific research works, but obviously if you're doing this study, you do have a hunch that there will perhaps be a correlation or causation.
Right. Yeah. So absolutely. I mean, we do think that we're going to find that the rate of bone loss is greater amongst women who take antidepressants in these categories compared to women who are getting therapy, because we think that there's an independent effect of the medication beyond the effects of just depression. So, it's interesting that depression itself has been also linked to fracture. So right now we have about half of the women enrolled, and most of our participants are women who are on drug therapy rather than are getting therapy. So, it's about 3 to 1. So we definitely need women who are getting therapy. And right now, most of the data that we've sort of taken a preliminary look at is the baseline data. And what we have found is so far, and again, the results are subject to change when we have a greater number of participants, but we found that bone density is lower amongst women taking antidepressants, particularly at the forearm. So it was interesting. We didn't yet see differences at the spine or the hip, but we did see them at the forearm. And the forearm is a site that is a different type of bone than the bone present at the other sites. It's called cortical bone. And it's also a site that's not always measured by all, centers that measure bone density. So here at Columbia, we do it in the setting of research, but we also do it clinically because we're a center for primary hypoparathyroidism, which also affects that type of bone. So it was that site that seemed to be particularly affected. Now, the groups did differ a little bit in terms of body mass index. So the women who are taking antidepressants actually had a lower BMI. There were also some racial differences. So the women taking antidepressants were more likely to be white than other races and ethnicities. When we adjusted for some of those factors, some of the differences in bone density did go away. Not necessarily all of them, but the other thing that we have preliminarily found is when we look for fractures in the spine using VFA, the only people in the study that had fractures were women taking antidepressants. Now, these are prevalent fractures, like we don't know when they happened. They could have happened before the person actually went on antidepressants. And because we, are looking at really relatively few women, that actually wasn't a statistically significant difference at this point, but I think it's definitely suggestive. Yeah, the other thing that we also have found so far is that women taking antidepressants were more likely to have falls in the year preceding entry into the study. So, the effects may not entirely be driven by changes in bone density, but there also may be effects on propensity to fall.
I understand. So one of the things that you said to me in your email when we first got in touch was that women in your study are actually going to get sort of free healthcare in a way, because they're going to get a free DEXA scan, a free that CT scan that you're talking about. So these are actually really useful and I know extremely expensive, even with the copay procedures. So that would be one way kind of to lure women in to say, hey, you're going to get a free DEXA scan, a free CT scan. Oh, and I have one more question. When you were talking about bone density versus what the CT scan measured, what is that? Bone what?
Well, we sort of call it bone quality, but what is being measured in particular is bone microstructure. So, inside the bone is a whole network of what we call trabeculi, and I have a model here that I'll show you.
Oh, great, thank you.
So I'm gonna. This is actually an advertisement for a particular drug, but I'll just show you what the model looks like. Let me see if I can get this in focus here.
Put it on the place as your face.
Oh, okay. Yep. Let me see. Still out of focus there. Well, anyway, it flashed. Yeah, there we go. So this is the microstructure network inside of the bone. And so, the more interconnections you have, the better and the stronger the bone is. So we look at that. We also look at the thickness of that thick outer shell, which is cortical bone. And then we have a bioengineer here, and we have the images analyzed so that you can also kind of incorporate all of the elements of structure and bone density from those CT images into a single measure of bone strength. And so that measure of bone strength in some studies has actually been shown to be a better predictor of future fracture than measures by DEXA.
Right. So one of the doctors I spoke to who's wrote this book called Estrogen Matters, Dr. Avram Blooming, was saying that, yes, bone density is a measurement, but it doesn't tell you the resilience of a bone. And the resilience of a bone really depends, he thinks, on, starting estrogen at the beginning of menopause. Now, that actually leads to me one of my last questions, which is, are you filtering women who've taken estrogen versus not taken estrogen? Because how does that affect your data?
Right. Well, so if women are currently taking estrogen or oral estrogen or by patch, they are unfortunately not eligible for the study. So anyone who's getting actively treated, with estrogen or another drug that alters bone density, we have to exclude. Women who took estrogen in the past are eligible as long as it's a year or more ago. So we would love to have those women. And, in part, we can do that because people are being compared to their own baseline. And, the number of prior users hopefully will be similar in the two groups. Yeah.
That's a really important distinction to make, especially since so many women are starting finally on estrogen right now.
Yeah.
So we have a small window to do the study before everybody,
Probably so.
Yeah. All right. Well, thank you so much. Is there anything else that you want to add to this? And you and I will talk after I turn off the recording, but this gives people kind of just a baseline idea of what you're doing, why you're doing it, and if they are eligible to do this. And the other important thing I think to say, and I'll say it in the article as well, is that it has to be within driving distance of Columbia University or Columbia Presbyterian. You're at Columbia Presbyterian.
168th Street.
168. So you have to be able to get to Columbia Presbyterian 5 times within 18 months.
Correct. Yes.
Okay.
Yeah.
That's great to know. I'm going to turn off the camera.
Okay, perfect.
We'll talk in a second. Hold on one second.